Let Martha and Lourdes work on getting Lourdes set up here. And I am going to go ahead and welcome everyone to our national, let me actually find my little notes here. It'll be easier for everybody. I have some notes. Great. I just wanted to welcome everyone to our learning session, our national learning session on COVID-19 and COVID-19 vaccines, looking at refugees, immigrants, and migrants. Migrant Clinicians Network, we are very excited to host this event, and it's part of our partnership with a CDC supportive initiative called the National Resource Center for Refugee, Immigrants, and Migrants. And we're going to quiz you on this, but it's the NRC RIM. That's our new partnership, and we're super excited to be a part of it. A couple of housekeeping items. First of all, this session is recorded, and anyone who has registered for this event will receive an email with a link to the recording. They'll also receive the resources that we'll share with you. So please do not worry about the session being recorded. It is being recorded and will be sent to you. And again, as we were practicing with our chat box and welcome you all from around the country, we really welcome your engagement. And so please feel free to use the chat box and feel free to chat not just with the panelists, but to put your comments and questions into panelists and all attendees. So we have a wonderful panel of clinicians and advocates around the country who will be sharing what's happening on the front lines with COVID-19 and vaccines. And I know just before I introduce all of them, I always want to acknowledge as we're a year in to the pandemic, how hard this pandemic has been for all of us who are working on this topic, and all of us who are on this webinar and who are part of the refugee, immigrant, and migrant community, and all of us who are serving them. It's has not been an easy year by any means, and we are anxious. We're anxious to start rolling out the vaccines and getting shots into the arms of everyone, but most importantly, some of the folks that have been on the front lines of this pandemic as essential workers and essential communities. So with that, oh, hi, Lourdes. Welcome.
Oh, hello. I found myself. Chloe, I guess I found myself here. Thank you so much for your help.
Oh,
thank you, and hello, everyone.
Hello, great. So I was just doing a little bit of housekeeping.
I could hear you. I mean, that was a weird thing. It kept telling me, asking me for a password, but I could hear you.
Excellent.
But I'm here. I'm here.
Oh, good. So glad to have you. So what I'll do now is I'm going to introduce all of our panelists, and then we will start off with Lynn after I do the introductions. But I've been remiss. Someone asked who I was. I should introduce myself. Excuse me. My name is Amy Liebman, and I am the head of environmental and occupational health at the Migrant Clinicians Network, and I am based here on the Delmarva Peninsula, looking forward to being part of one of our many members here around the country here, but hopefully the eastern shore of Maryland and Maryland will be well represented. So let me go ahead and introduce our panelists. I'll start with Lynn. Lynn Bata is a public health nurse at the Minnesota Department of Health who serves as the immunization program clinical consultant. She has over 20 years of work in immunization, and she provides works as a subject matter expertise with the Minnesota Department of Health and their immunization programs. Additionally, she has worked on vaccine-related safety and vaccine hesitancy. So she has a lot to offer. And also, she's been just a little bit busy this year in that she has been appointed, last year, she was appointed to the CDC's Advisory Committee on Immunization Practices. And so she's been probably at the probably very busy and at the center of thinking about the rollout. But also, I'm sure bringing to that conversation was her work that she's done with Somali parents and the MMR vaccine. So we're excited to have you, Lynn. And then I will introduce Dr. Andrea Caracosas, who is here from Hope Clinic. She's dedicated her whole career. She once worked with us at MCN, has dedicated her whole career to provide equal access to healthcare for all. And she's now the executive director of Hope Clinic, which is a federally qualified health center that provides care to a large multicultural community in Southwest Houston. And Andrea is pretty amazing. She started off with a clinic with 5 employees, and it now has a staff of over 200. And Hope has become a nationally recognized center for its quality and innovation. So welcome, Andrea. And next we have Lourdes Villanueva. Lourdes is the Director of Farm Worker Advocacy at the Redlands Christian Migrant Association. It's an important family service center and migrant head start center that serves farm worker families in Florida. At age 11, Lourdes came with her family to harvest fruit and vegetables here in the United States. And in the early 1980s, she was the mother of 3, and she came to the Redlands Christian Migrant Association because she wanted a safe place for her children to be while she cared for, while she and her husband harvested tomatoes. She went on to become RCMA staff, got her GED, went to community college, and eventually earned her bachelor's degree. And she now serves as Director of Farm Worker Advocacy for RCMA. And she has received numerous awards for all of her advocacy. If you Google her, she's just amazing. But one of the more amazing things about Lourdes that I love is her interview that she did for StoryCorps with her son, which is just a really beautiful tribute to Lourdes and all of the work that she's done. And last but not least is the chair of MCN's Board of Directors, Dr. Eva Galvez. She is a board certified physician at the Virginia Garcia Memorial Health Center in Oregon. And since she got her medical degree in 2004, she has been working in federally qualified health centers. And she is also the daughter of Mexican immigrants and agricultural workers, and has a special interest in the health issues facing immigrant families and farm workers. And she's passionate about providing high quality, culturally appropriate care to her community, as well as being an advocate to improve the health and well-being of vulnerable populations. So I am super excited to have this amazing panel with us today. And we're gonna start off with Lynn. And we're wondering if you can just give us an overview of your work around vaccines, and then touch on all that interesting work with the MMR vaccine in Somali parents. And then what can we learn from this as we move forward with COVID-19, and how is it impacting all of your work you're doing with the refugee populations?
Sure, thank you so much for having me this afternoon. It's quite an honor to be a part of this panel. I am a public health nurse, and I have been working at the State Health Department for the last 20 years. And all of it's been in immunization. And probably the common theme throughout the work that I've done in the world of immunization has been vaccine hesitancy. And I've watched it start as people circulating books and pamphlets to huge disinformation campaigns on the internet and other social media. And so it's hard to keep it up in terms of getting good information to people as fast as they're getting bad information. But it's important for them to access information. And I think the work that I had done addressing some vaccine hesitancy among our Minnesota Somali immigrants has taught me a lot about equity, a lot about lack of access, not about access to the vaccine itself, but access to good, reliable information and access to dialogue. And the work in that started probably in 2009 when we were hearing from some of the Somali parents within our Twin City community, which is Minneapolis and St. Paul, Minnesota, that parents were refusing the MMR vaccine, and that a parent went on TV and said that she was sure that the MMR vaccine caused autism in her child. And I just happened to see that on TV, and I just went and thought, oh my goodness, this is not good information. That's reaching a very vulnerable community in terms of their ability to seek good information and find answers to their questions. And so we kept tabs on it, and it wasn't though until 2011 that we really got involved, and it was an outbreak that we saw in which a disproportionate number of cases were among Somali children. So we began to have conversations with the community, but I would say we were being typical public health officials. We were doing the population thing, get out information and then they will change their minds. And we put out some PSAs, we put out some posters, we actually did a video that was in Somali and also translated into a couple other East African languages. It was great information, but it did not resonate in the community. And I finally told the managers above me, we need people who know how to access the community. I'm not that person. I don't speak Somali. I'm an unknown. We need some trusted members of the community to represent the health department and the community both. And that really became a turning point in our response to a lot of the hesitancy we're seeing among Minnesota Somali parents. We found that, or we learned that one parent's opinion isn't all parents' opinion. We really needed to do more key informant interviews, and that needed to be done in the native language so that some of those cultural innuendos could be understood and picked up and explained. I would say in my role, I know that personally a big thing that I have learned is that I'm not useful if I'm trying to keep things in control. I've learned that it's really important to use the white privilege I have to empower my colleagues to overcome some of the systemic barriers that are racist, and then allow them to take over and really call the shots, really identify who the key influencers are, to be the ones to frame messages for the community. And that became an important factor in how we responded to another measles outbreak in which we saw 87 cases. I've lost, that was in 2017. Again, the majority of whom were Minnesota-born children of Somali ethnicity. And but what we found was that the colleagues that were in charge of working with the community knew who to round up, knew where the messages needed to go, had already formed an advisory group for public health, where those individuals could be messengers, they could be advocates, they could direct people to good information, they could be telling parents what to do and where to go. And we really saw a fairly rapid resolution of the measles outbreak that occurred in 2017. when we first heard about the outbreak, there were already 4 cases. And the 4 cases came from a daycare that was run by a Minnesota Somali woman. And we were very concerned that this outbreak would spread rapidly, that we could see hundreds of cases. But because of the already established avenues of communication that the colleagues had set up, we were able to get information out very, very quickly. And instead of hundreds, we saw less than 100. And I really attribute that to the coworkers. And if I had been thinking about it, I think I would have deferred to one of my colleagues to talk about this, because I really have been trying to elevate how important it is for my colleagues to be able to share their story rather than hearing the story from me. As we think about this, there's a few things that I was jotting down in addition to empowering and resisting the temptation to be in control, because I think that we have that authority in public health, and we need to be very discreet or very careful with that power, and be willing to step back and let others be more powerful. To be nimble in expectations. A lot of times in public health, we have performance expectations, but they again are very driven by the system and not driven by what is actually effective in a community of people. And so I think that's an important, we needed to know that we have to pay for the services that we want people to perform to reach out to the community. That's very important. And that's been a really key portion of our response throughout the COVID outbreak or pandemic, is to get those partners up and going right away. And I think the other thing that I need to keep doing, and that if you are in a position of white privilege in your institution, your system, is to be that nail on the chalkboard, to always be raising the issue of equity, to always be thinking about how is this information getting to people who don't have immediate access to information? How is this service getting to people who may not even know that that service exists? And to constantly remind the decision makers that it's not enough just to do it. We really have to make every effort for an equitable action in what we're doing. And with that, I'm going to turn it over or take any questions.
Yeah, I think we have time for a quick question. And I just wonder, Lynn, if you could, I'm looking on the, and Del, let me know if I've missed anything here, but I'm wondering if you can just take a moment and from your experience with in COVID-19, and you did talk really well about the importance of how you engage the community. And in terms of the COVID-19 and perhaps some of the recommendations that are being made for the rollout, are there some additional things for us to be thinking about that, based on all of your experience, that we should be doing as to try to reach some of our hard to reach refugee, immigrant, and migrant communities?
I think in the beginning of the epidemic, we really learned that some of our other governmental partners were really critical, including some of the liaisons from our employment agency, so that they could be advocates and communicators between employers and employees. That was a huge communication breakdown. In terms of vaccine hesitancy, I began to, because that is one of my assignments, is to really become that subject matter expert to the team of community liaisons that are serving various communities, not just the Somali community, but other African communities, Latinx communities, Asian Pacific Islander communities, our disability community. So there's several, American Indian is another one. They represent the communities, and as we've had dialogues leading up to when vaccines started to be distributed, there were a couple hesitancy themes that really arose, and some of them are common no matter what your background is, and some are very unique. And the most common stream of hesitancy that we hear about, and I think CDC just put out a publication today about it, is that the vaccine process for making this pandemic vaccine went very, very fast. And people were very concerned that steps were skipped. And so really learning some talking points about there was no step skipped in the making of this vaccine. There were two advantages when we started out. One was that we put in a lot of money, so a lot of steps could be done one on top of another, and that really sped up the process. And the other piece is that a lot of the pre-clinical work before clinical trials happened had already been done over the past 20 years. And so we really had a jump start on that, the same standards for safety and the same standards for a vaccine that works were put on the manufacturers as they would be for any vaccine that would come out and be available to people. So that was the first. The second is much more related to our Black, Indigenous people and other communities of color, and that's some of the historical and current racial injustices that they have suffered, and makes them very suspicious of government entities, and especially some of the unethical studies that have been performed by both local and federal public health departments that really have broken down the trust barrier. And in parallel to that is the lack of respect and support to our Indigenous peoples and the nations that they belong to, that we need to recognize that sovereignty. We need to recognize, again, some of the past injustices and the inequities that the Indigenous people are experiencing today. And those acknowledgements to our communities are a very important part of starting a conversation to provide information to the communities, to start a dialogue. The dialogue allows people to expunge their concerns and their frustrations with the systems, and by acknowledging that, and it allows them to know they've been heard and they might be willing to listen to the information we have.
Great. Thank you so much. That your perspective is really important for all of us. We're going to hold off on further questions right now, and we're going to move to Andrea Caracosas from Hope Clinic. And Andrea, I'd like for you to just tell us a little bit about the population you serve at Hope, and also you and I have chatted a little bit, and the vaccine acceptance among your own staff at a federally qualified health center has been pretty impressive, and wonder if you can touch on that and then talk to us about your work in the community.
Thank you, Amy, and thank you everybody that's joining us in this talk, certainly. So just a little bit background on Hope Clinic. Hope Clinic original name is Asian American Health Coalition of Greater Houston. And we changed the name to doing business as Hope Clinic because we wanted to include all populations in our service. So with that said, Hope Clinic has a unique role in Houston. It serves the very multicultural and community in Houston. Our staff here speaks over 25 different languages, and at any point in time we serve people that come from 60 to 80 different countries. We very much work very closely with the refugee and resettlement programs in Houston, a little bit defunct right now, but it's still seeing a lot of immigrants. And the clinic was originally founded by 4 Asian women who wanted to bridge the language barriers and do exactly what Lynn's talking about, provide the community with reliable in-language, culturally appropriate and sensitive information that would really speak to them personally, and not just be a translation from a different perspective. So that being kind of the root of Hope Clinic and the spirit in which we do business, we've certainly grown over the years, and we have no majority of patients. We have 25% are Asian, 25% are Hispanic, 25% are African and African American, and 25% are white, which includes a lot of Middle Eastern refugees and Europeans as well. And so a very, very interesting community. So some of the issues that Lynn talked about access to information and equality, our equity, are really important in patient care and in how you relay information to communities. But more than that, I think that we're here to answer their questions and to listen to their concerns. And I think that that's something we don't do enough. We're very used to pointing the finger and telling people what to do, translating educational materials and giving that to them. And sometimes we don't really answer their questions or address their concerns with those materials. And so many has now, about 14, 15 years ago, when the clinic started, we put a group together around hesitancy to have pap smears and to test for hepatitis B, and also do a lot of mammograms, and all because they're all kind of related to cancer. We called it the Asian Cancer Council. And what we did is we cultivated a group of organizations we started with 5 organizations that wanted to work around the issue of cervical and breast cancer and hepatitis B. And we provided with, funded by the Robert Wood Johnson Foundation, we helped all organizations, including ourselves, to learn how to develop a good board of directors, how to write grants, how to administer funds, and also how to develop messaging. So that organization is now grown to over 25 different organizations. So it is kind of a incubator for community-based organizations. So different groups, Somalis, Bhutanese, Burmese, they all want to develop their own the community organizations, which I think is fantastic, because it helps them have a one-point reference for information. And some of the basic agreements that we have when they join the Asian Cancer Council, which of course includes more than Asians now, is that we all agree to speak one message, one language, and that to work together to give the same information to all communities, to not duplicate services, to collaborate. And so those basic principles still stay true, regardless of which issue we work on. And over the years, we have worked on census, on voter registration, not just health issues. And of course, now we have worked on first COVID testing, and now we are starting our work with the immunization campaigns. Another issue, of course, we talk a lot about misinformation, and this is one of our strategies to address the misinformation, is really to make sure that we are vetting, not us ourselves, but that the whole group is vetting the information that's coming out, that when we talk to media or ethnic media, that we're all kind of saying the same things in giving the same message, even if it's in a different language or a different format. And the other thing, of course, is that we do have those partnerships with the ethnic media. Immigrant communities rely a lot on their own, printed media in their own language. There's magazines, newspapers, YouTube channels, TV programs, and I think that having a pulse on all those things is only possible by collaborating with those community organizations. Hope Clinic has started doing a lot of, I think we got the pulse of COVID before everybody else, because as soon as the news came in December that there was a strange virus in China, no one wanted to eat at the Chinese restaurants around our area. And let me tell you, there's over 200 restaurants around Hope Clinic, so it's a big hit to the businesses. And so we learned early on that we needed to manage the information that came out of Asia Town and not present the virus as the Chinese virus, but actually a real global threat. And that brings me to the other subject, which is global news. Immigrant communities, whether it's Somalis or Burmese or Chinese, information has become globalized, and so sometimes the messaging is not just the messaging that comes out of the CDC or out of our organizations. It's messages that come from overseas, and so I think that having a solid presence on social media is really critical. People, that's how they relate to their countries. They want to look at their local news. They want to hear the local gossip. They want to keep connected to their cultures, and information gets transmitted as well that way. So I'm going to pause a little bit there and just kind of talk a little bit about what we have done regarding our COVID immunizations. So we are very grateful that we've all done about almost 900 to 1,000 immunizations thus far. We've been, the first role, of course, was to our staff and their families. And I feel strongly about them immunizing family members, because it denotes a little bit of difference to the senior communities and in their own family members and caring for your own personnel. I was one of the first ones to get immunized. I am not 65, but certainly we're in the healthcare industry, and I've been at the clinic day in, day out. But mostly I did it because I wanted to show my staff that the vaccine was safe, that I was willing to try it, that I was, I think that when we sent out the survey before the vaccine rolled out, we had about, maybe 50% of the staff wanted the vaccine, another 50 not. But after the first round, when they saw that all the leadership got the vaccine and we were, taking pictures with our arms with our needles and, showing our bruises 2 days later, that people really got motivated. And on this next round, we immunized the rest. So thus far, we were probably immunized around 70% of our workforce. Some of them have not been immunized because either they had COVID before or they have severe allergies to the vaccine. So I want to say that we reached the vast majority of our staff. I think that by the end of this February, as vaccines roll out, we'll reach the rest of the staff. People are participating in the vaccine campaigns. They are proactive, talking about the safety of the vaccine and addressing their own personal fears. I mean, not everybody is a friend of the needle, and vaccines carry their own stigma, no matter how welcome they are. People are definitely afraid of that needle, no matter what. I just want to talk a little bit about the vaccine hesitancy in our communities, a little bit addressing some of the points that Lynn had. Well, you were at the beginnings of the campaign, and we haven't gone out in the media and talked a lot about the vaccine. We've done a special event for Vietnamese seniors, and we had 500 seniors show up with their families or being brought by their families. And I think that shows that people are very eager to take the vaccine. And, I think that little by little, we will conquer that hesitancy. I am cautious sometimes to, encourage everybody to take the vaccine and rile them up at this point, because we don't have enough supply. And sometimes it is very, when people can't get the vaccine when they want it, they may give up on getting it altogether. So I'm very cautious in pushing the vaccine by groups. So we've done an event for the Vietnamese. We'll do another event for the senior Chinese. Definitely reaching out to some of the harder to reach populations, such as the Bhutanese and the Burmese. We have a stronger roots in their own medicines, and we've seen big outbreaks of COVID here in our communities. and bringing them within their own terms and within their communities to get immunized later on. So I can tell you this is a work in progress. We don't have a secret bullet to the immunization and how it's going to roll out. And we learn something new every day with the vaccines, but I am just pleased that we've been at least to be able to have at least 1 or 2 immunization events a week thus far. And I entertain any questions that you may have. Amy, anything else you want me to address?
That was really, really helpful, and I'm still super impressed with all the work that you are doing. Do we have any additional questions for Andrea? I certainly have a couple that came in that we've been thinking about before, if we don't have any in our chat right away.
There was some interest in a little bit more information on your special events for seniors. There's no more information in terms of context, but Andrea, perhaps if you could talk about how you decided to start there and then how you rolled it out.
Well, I think that we started with the Vietnamese seniors because they really wanted the immunization. So they really asked for it and they were ready for it. And we had some providers that were championing that. So of course, we jumped onto the opportunity. We actually partnered with the city for that. It was a 500 people event. And, we got our our systems of immunization pretty down. We fill out all the forms ahead of time. They get registered under a tent in their car, and then they just drive close to the clinic. They get off the car. They get the nurse. There's a bunch of nurses waiting for them. They just, walk them or take them in their wheelchairs into a exam room and give them the immunization. And then they wait in another area for 15 minutes where they're, provided with all the information about their card, and then the next day to come back and hand it off to their caretakers thereafter. So we had our system down, and it was a fantastic event, very heartwarming. People came in with their wheelchairs, their walkers, and some of them took Metrolift, and we're, in healthcare, you always feel grateful for the work you do.
Andrea, one more. There's a couple of questions, and Brian, I'm going to get to your question, I think, after the next couple of panelists, but there are a couple of questions in terms of, one's a simple one, is the post-vaccine document that you get when you get your vaccine. Is that being translated? And then if you could speak a little bit more about some of the hesitancy in some of your different groups, if you want to touch on that some more.
Well, we did translate the intake forms and not the card. The card is pretty self-explanatory, and you want it in English because it's going to maybe be your passport to travel, or is it going to something that you're going to have to show someone else. But we did translate some of the documents that were filled out by the patients. We provided also oral translation throughout the process, and I hope that answers your question.
That's great. And then a quick one for the last one, and I'm actually curious because I've had some conversations with you about vaccines, but did you encounter or was that a concern for you that people may have been coming outside of your service area to get a vaccine?
No, never. I think we have to vaccinate everybody that wants a vaccine as soon as possible. We're seeing new variants of the virus. We have this, this is a unique opportunity to try to immunize everybody that wants to get immunized as soon as possible. That's a little bit of my philosophy. With that said, we try to reach out. We have to meet the state mandate, which is to immunize either healthcare providers over 65 or people with chronic diseases, which certainly I agree very much on. But there's no lack of that, so we've been immunizing plenty of seniors.
Great. Well, thank you so much, Andrea. We'll get back to there's some really good questions coming in for you and Lynn. We're gonna get back to some of those questions at the end. And now let's have Lourdes talk to us a little bit about the work that she's doing in Florida. And I'm trying to maybe you can help me unmute and turn on the video, Martha, for Lourdes.
Seems like I'm on mute. Can you hear me?
Yes, we can hear
I
you.
can hear you, except you're showing up as Amy Liebman for some reason.
Okay. I'm good with that.
Let me see if we turn off the video there, Martha, for some reason. I'm not sure what's going on, but turn on Lourdes's video and my video. Maybe we can see Lourdes. There we go. There you are.
Okay. Found myself again.
Yeah.
Okay. As you said, my name is Lourdes Villanueva, and I am the Director of Farm Worker Advocacy for the Redlands Christian Migrant Association. It is a very old organization. It started back in 1965 in Homestead, Florida. And that really came about a lot of accidents happening with children in the fields with the parents. There was nowhere for them to be taken care of. And it was started by the Mennonites. It was a group of missionaries that would come down, and they opened up 2 centers and to keep the children safe. And at the time, the issue was, again, like everything else, these were, again, immigrant families that did not really have a lot of trust of these nice people. Why are they being so nice to us? And they were not very successful in getting the kids into the places, to the 2 childcare centers that they had set up. So they heard about a man named Wendell Rollison, who was working with the farm worker community, and they enlisted his help to make sure that families knew that they were there and that their intentions were to keep their children safe. So again, it didn't happen right away. And then his suggestion was like, well, where are the kids? And they were like, well, they're staying a lot with the grandmothers or the elders in the camps to keep them safe, because they knew that a lot of people were already taking issue, including them. How can we keep our kids safe away from, falling in wells, tractor accidents, you name it, it was happening. So that's where the philosophy really started, and it continues to this day, that RCMA hires staff at all levels from the communities that are served. And that's why I am here, currently working with RCMA for a little over 40 years. And that goes across from the beginning of the day to the current situations that we have. Going back, like I said, with Wendell Rollison, then later he was the first executive director back in 1965. And from those 2 centers, we really have grown to about 68 childcare centers. These are buildings. Then we do have quite a few programs in other locations, some schools, before and after school programs, just different ways that we can serve the families and the children where they are at. We are still very rural migrant focused because, as you can see, we do enjoy a lot of fresh fruits and vegetables, and they are grown here for the most part. I think here meaning in this country. So Florida is one of those states that has a lot of agriculture. Agriculture is only second to tourism in Florida in terms of industries. So we serve anywhere from 6,000 to 8,000 children a year. We are in 21 different counties. So we are very widespread. We have some concentrations in different counties depending on where agriculture is still alive and well. There's communities who have been wiped out in terms of because of housing that has to go up in different places. And of course, agriculture land is quickly disappearing. But for now, we still have quite a bit. And a lot of it is still tomatoes, strawberries, and everything in between. A lot of vegetables that are grown and that are hand-picked. And those are picked by families. There's a lot of misunderstanding as to, who are those people. And yes, we continue to be those people. We are still seen a little differently in a lot of these communities, even though we have been around for this year. We're working on our 56th year of service. RCMA is. And again, we have gone to the different places, different counties, at the invitation of either families who say, we go to X place, Ocala, out of all places that nobody, I did not even believe that there would be farm workers there, because Ocala is, fancy horses and all of that. But, there was a parent that said, chop in my truck and I'll show you where the families are. And I mean, I was surprised at my age that yes, there were plenty of farm workers in that area that pick peanuts of all things. Again, we have had a revolving door in terms of where farm workers are coming from. It used to be the very traditional, just like I did, traveled with my family back and forth. I would still consider Texas our home. We would go back and come back and just do our thing and go back home. Then lately, there has been a lot of families coming in from different countries, Central America, South America, speaking different dialects. So doing all this work with the families, what we have, what we have to show for is that we are very trusted in all of the communities. And that's why we also take that responsibility very seriously. We are very hesitant as to who we invite to visit the families in their locations. But we do have a lot of different, I would say, visitors to our program, so they can see the work that we do, because we are very proud of what we do. We have about 1,700 employees, so we are a fairly large organization. We have programs that are year-round, but the majority are still very seasonal. That's depending on when the crops are being harvested. And when you say migrant farm workers, that's what it is, migrant, they migrate. Right now, we have a lot of the families here in Florida that will be traveling up to all the states that grow any crop. We still have a good number that goes straight from here, from Florida, Central Florida, to Washington State. And only because that they do tree crops, and they're like, we want to go somewhere where we don't have to be moving 10 times throughout the summer. Then we have the ones that go from here to Georgia, South Carolina, North Carolina. So you will see a lot of these families all over the place. So again, in terms of what we do with the families we provide, we also have 2 charter schools, and they're bilingual, and we are very proud that our kids are doing very well. And of course, that gives us some good ratings, so that they can see that all that we need as those people, it's an opportunity, and that we are actually pretty smart, and that we can make it out there as well. And that's where a lot of our work comes in. We work with elected officials on both sides. I mean, whoever wants to work with our families, we are there. We try to encourage changes to the systems that are not too friendly to our families. Florida continues to be Florida. And I was talking to someone this week, and I said, if somebody wants to come and do a case study of what can go wrong in any situation, come to Florida, because this is where it's going to be. Things are not where they need to be after all these years. So whether it is a hurricane or anything that happens, many times it is like 2 weeks before even the Red Cross shows up to where we are. So we have to learn to live and be ready to support our families where they are. And we do play very well in the sandbox. We partner with anybody and everybody. And I think before I forget, I have to say that we worked a project with Amy a few years ago, because, again, at the time I thought we could change the world and do away with pesticides. And of course that didn't happen. So then what is it that we could do? And so we did some hand washing sinks, sanitation stations outside of our building, so that when families come to our center to pick up their children, they can wash up. And we also provide clean shirts if they need one before they take their kids home. So now when COVID came about, the first thing that they said was hand washing. So we were ready because just about every one of our buildings have those hand washing sinks right outside the door. And so they're there. We have been able to put in some more so that we have them in every place that families need to have that precaution. So again, I had my kids in the program. I learned what needed to be learned in terms of the communities and how systems work. And then I eventually, yes, graduated with a social work degree. But I still think that I know what I know and I do what I do because of my experience. I have been there and I have done that. I still do home visits. I do know exactly what the living conditions are. And I still have a pretty good relationship with all of our families. That's my goal. I feel like I need to be connected so that anytime that I'm going to speak about what our communities need, it is not because I read it on some little magazine or somewhere. I've been there and I know what it's like. So this year when COVID hit, it was one of those things that it was like, wow, everybody's hurting. I mean, everybody was closed, everybody was being forced to close, and we were not any different. So what is there for us to do? So first of all, it was like the first thing everybody shut down and curfews and different things. And it was like our families do not have sick time. They do not have any benefits. So they had to continue to work because here it was peak season for strawberries and for other crops. So it was like, what can we do? And at the time, it was like working with the growers. I mean, they are your workers, they are our families. So how can we make this happen that they're not going to be harassed for being out at 5 a.m. driving to work? So we made arrangements to where the employers gave them a letter saying these are essential workers and they're on their way to work, so that they would not be detained or penalized for being out on the road on their way to work. So we have very good relationship with the good growers, because like everything else, there's good and bad doctors, there's good and bad growers, and we make it our business to really know who treats our families with respect, and that's who we work with. We also work with the associations, and we also have a good relationship in terms of we know what they are needing, and we also have the trust that if we say something is wrong in this place or that other place, or this is happening to our families, that they trust that that's what's happening. And we also facilitate a lot of those conversations. So again, there was a little step for people to at least get to work, but then it was like testing. I mean, how can we get testing? And we are in the rural communities. It's different and it's difficult. But for me, the most difficult part that we were in places where we're 30 minutes southeast of Tampa. And we did not get testing to that location until June 15th. And I have it ingrained in my brain because that's how long it took us to get the very minimum of having some COVID testing. So then, of course, we went around the state in the different places trying to facilitate that our families would get at least what they deserve. They're human beings, even though I know that recently there has been a lot of negativity and the narrative has not been very helpful for our families, but they are families who work and they are families who love their children and they also want to be healthy. So that's part of what we have always tried to do, is to be that link in all of the communities that we are in. So we sort of kind of, I don't want to say we got all the testing that we needed to have done in the communities, but then our families started leaving. I mean, they went to Maryland, to all the different places that they have to go to. And many times, you know, what it is like, oh my God, you know, the end of the world, because those people are going to take all these COVID with them wherever they go. So then now with the vaccinations, we are saying, yes, we need help in getting our migrant farm worker families vaccinated sooner than later. We are still struggling. Again, I'm reminding you again, this is Florida. We have had some hopes here and there, but nothing has really worked out to where we have a commitment from anybody that says, yes, farm workers will be vaccinated sometime soon. Because as soon as the work is done here, they will be moving to other places to go work. So I think that it's to the benefit of everybody, for us here, but then also for the receiving states when they go up north, that they have been vaccinated. But as of now, we're not anywhere near where we think that we're gonna have some families vaccinated before they leave this area.
Lourdes?
Yes,
Can I interrupt? Can I interrupt you with a couple of questions?
Sure.
So when we chatted, you talked about a couple of things that are coming up in the questions. And so one question is, how are you going to help address the situation now in terms of this requirement for proof of residency?
Well, we are, first of all, educating people that when they say residency, they mean that you live here in Florida, that you have that is not, you're not a tourist, because that came about some things that were not so positive in some places. Miami, of course, in Florida, where people came from other places who were just here and the vaccine was available. I don't even know if that's going to be of any benefit to anybody, because it's not like they were here to get the second dose. So right now, what we are working with is to get as many. We have started to do some parent identification cards because these families had nothing. And so all that says is that this person, and they have a picture, and we did have, we had an attorney review and say what it is that we can put on there, which is their address, their picture. But again, these are just the families that we serve, which we do not serve. We are a drop in the bucket in terms of the families, farm workers in the state. But we are also working with the state to clarify their policies, that it is not about legal residency. It is residency that you live here. And so we're also working with the growers associations so they can also help in possibly giving something that says that these people are here X number of months, and therefore they are residents of whatever county or town that they are in. But again, I mean, we are working with anybody and everybody that will help us to push this forward. The other thing is that we do have very good relationships with the consulates. And again, that is because the families that we do have a good number of Mexican families, and the consulates in Florida have been very helpful. And so we do have a very good relationship, and we are hoping to also get somewhere with them. We are really enlisting anybody and everybody that can help us with this situation.
Thank you, Lourdes. I think that you know, you really sort of underscored the importance of trust, of all the work that you do with the community outside of COVID. So when COVID arrives, you can talk to them about the identification cards. You can talk to them about solutions, and you can sort of build on some of all the partnerships. I'm wondering if take a couple minutes, if you could just touch on, what are you hearing in terms of hesitancy? It's an odd question because you don't have any doses yet.
No.
So what are you thinking, and how is our RCMA, your family is thinking about if there's hesitancy, and how are you addressing it?
Well, we have been addressing it from day one. We're dreaming that it's going to come down one of these days. So we do go over the same thing, because with some families, we even have issues with the children getting their vaccinations. So it does take a lot of work, but we have been at it from day one. The other thing that we do visit the farms themselves. I mean, when people are at lunch, their lunch break, we take every opportunity that we can to get the word out. With whatever the issue might be. Of course, right now it's COVID. So it is, and we also have some very good materials, and of course we borrow a lot of your material. And we also have a very good relationship with the Rural Women's Health, who has done a lot of material in the different indigenous languages. So we do try to be proactive with a lot of these issues that we know. If it affects America, it affects our families, and many times negatively, probably 10 times more.
Right.
I think I saw a question about using the real names. For the most part, when they enroll their children, and again, and that's when I say we have to be very careful as to how we go about anything and everything that we do. We do have a good number of mixed status families. It is not like every single farm worker is undocumented. So I also want to highlight that part, because sometimes, there's that connection, or their farm worker equals undocumented. Not necessarily. We do have families, entire families, that have, but again, they will have one or two people in their family that they do try to protect and will protect, and will leave a location if they're not treating the undocumented people properly. So then again, in terms of getting information to them, we do it in every way, shape, or form that we can. We have their precious babies, and we do have that opportunity to see them every single day. Right now, we are pretty much up to capacity. We started following all of the guidelines and more, because we always want to be careful that we don't want to be like, oh, well, of course, that program that runs the program for those people, of course, they're going to have issues. So we always make it even harder on ourselves. Our staff are really awesome. We have a lot of long-term staff, and they are here for the right reasons, because everybody that does childcare knows that there's no money in childcare, and especially not in non-for-profits. But we do the temperature checks of the parents in the morning, the children, and how we bring them in. Parents cannot bring their child all the way inside to the building, which is very anti our own way of doing things, because we were, up until COVID, very open door. You can come and see your kid in at any time. But right now we're doing things differently. We have done parent meetings outside, and it is funny, but then I feel very proud of everybody that even the maintenance men who set up the chairs outside, they are with a little measuring stick, making sure that the chairs are so far apart. And one time somebody moved some chairs, and oh my God, now everybody ties down the chairs, and they're gonna make sure they don't move the chairs. So
Thank you, Lourdes. That's I want to just make sure we have some really good questions coming in, and I also want to give Eva a little bit of time here, and then there's a lot of questions coming in, and we'll let Eva speak, and then circle back around to get some of these questions for all of our panelists, if that works for you.
Sure. Thank you.
Thank you so much. Here's Eva.
Thank you so much. Thanks for all of the wonderful comments. I've been learning so much, and I am aware of the time, so I will definitely keep that in mind as I speak. Once again, my name is Dr. Eva Galvez, and I'm a family physician, and I work at a community health center, Virginia Garcia Memorial Health Center. We are located in Northwest Oregon, right outside of Portland. So we have several community health centers, and we are at the edge of the Portland metropolitan area, and then are rural. So many of the patients that we serve are living in rural areas of Oregon. Much like Lourdes, our clinic was started after a young migrant farm worker in the 1970s lost her life because she couldn't get access to healthcare. So the community came together, and we built this clinic, Virginia Garcia, in her honor, and we're here today. Our clinic serves a relatively young population. Only 7% of our patients are over age 65. Most of our patients are really young. Latino patients, many are migrant and seasonal farm workers. Many are working in meatpacking plants as caregivers, janitors, food service. Many are uninsured, and 98% live below the federal poverty line. And not surprisingly, because of all of these barriers, we see patients with high rates of chronic conditions, diabetes, hypertension. So, it's not surprising that our community has been disproportionately impacted by COVID. While Oregon has a relatively low positivity rate, one of the lowest in the country at 5%, our community, our positivity rate has hovered around 20% around throughout this entire pandemic. So we've been hit really hard, and our patients have certainly been suffering, not only health-wise, but loss of work, and then there's been a huge psychological toll that is taken on the families. So, you know, as we continue to offer testing in our community, which we continue to do, since the fall, we really have beginning to prepare for vaccines. And so a lot of our work in the last few months has been geared towards preparing the community for vaccines. So I would like to pause here and talk a little bit about some of the challenges that we have experienced as we begin to get ready for the vaccines. And I like to break that down into two things: hesitancy among the community as well as vaccine access. So as far as hesitancy, much of what the speakers have touched on are the same issues that I'm hearing with my patients. Many of my patients are distrustful of the vaccine. They worry that the vaccine is not safe. They worry about the potential for dangerous side effects. They're concerned about the long-term risks. But in addition to these risks or concerns that I'm hearing, there's also some other more, I would say, kind of more conspiracy theory type of concerns that I've been hearing from my patients. One of them, many people have been telling me that they're concerned that maybe the vaccine is a way for the government to control the population. Other people have told me that the government is out to alter the DNA of communities of color. I've also been hearing that the vaccines were developed using aborted fetal cells. So these are many of the comments that I'm hearing. But I think it's important to really highlight something that Andrea said, is that, you know, much of these beliefs or concerns that people have are concerns that people often are hearing on social media platforms, but they're also hearing it from people in their countries of origin. Many of our patients are really connected to their families back home through social media and video chat. And so what people are hearing back home is definitely influencing them here. For instance, back home in Mexico, many patients are hearing of family members or friends who are going to the hospital and then dying. And so people have told me that, you know, people see these hospitals as a death camp, or that hospitals are withdrawing care, or hospitals are killing people. And so they feel like they can't trust a vaccine if they can't trust the healthcare system to take care of patients. And I've had a patient 2 days ago tell me that he's from Michoacan, from a small town, and he just found out that one of the local businesses there was arrested for selling and administering a sham vaccine. And so now all of those people in that town are really wary of getting the vaccine. What we see here is we see a distrust of people from, you know, their governments back home, the healthcare systems back home, but that's also amplified by a deep distrust of our healthcare system and our government systems here, because our government has often not been good to our patients. There's been a lot of anti-immigrant policies, anti-immigrant rhetoric, and that has also raised people's fear and suspicion. And so they wonder why they should trust a government to have a vaccine that is safe. But we also have to realize that oftentimes when people don't have access to information that's in a language or in a format that they understand, it's easy to turn to social media platforms, or it's easy to turn to word of mouth. And we know that those resources are often not reliable, so it really perpetuates these myths. Now, access has been really tricky and has also been a huge hurdle for us at RFQHC, and particularly in our state. In Oregon, and I'm sure this is similar in many other states, the rollout of the vaccine has been slower than expected and has been somewhat chaotic. And this has really stemmed from some infighting within our state about who should get the vaccine first, given that there's a limited supply. Back in January, our state was expecting to get a large mass of vaccines from the federal government, but that didn't happen. So what that forced us to do was to choose between who would get the vaccine, right? Would it be seniors, people of color, essential workers, educators, incarcerated people? And so after, much discussion and vaccine advisory groups who were providing recommendations, what happened was that educators and childcare providers and our incarcerated population was moved up in our priority list. And so that has bumped our seniors and our younger population or our communities of color. So for instance, in Oregon, we're just finishing vaccinating our educators, and this week we are just starting to vaccinate our seniors. And so this has been really hard because we don't know when we will be getting the vaccine. So as we prepare, it's difficult to know when the shipment will come. So I want to just make a couple of points there, because one of the things that it's important to know about Oregon is that Oregon has a very, very young Latino population. So when we talk about vaccinating our seniors, that really does not include many Latinos or our essential workers. And so when we have these backups in vaccinating people, what happens is our communities of color and our essential workers continue to be bumped. And so that really is a concern to me as a healthcare provider who works with this population. But I want to just pause here and talk a little bit about the vaccines that we have been receiving, because the state really is working hard to try to offer the vaccine to the community as different shipments come in. But the way this is happening is that people have to sign up on a computer, and it's really first come, first served basis, and people must drive out to different areas in the Portland metropolitan area. So it really puts many of our patients at a disadvantage. Many of our patients don't have reliable transportation. Many of our patients don't have computer or internet access, or just aren't tech savvy. So when you're asking people to sign up for a vaccine through a computer, obviously this is really difficult for our population. Now, at my community health center, we have managed to secure enough vaccine to vaccinate the workers. And we have also been able to vaccinate on a couple of different occasions some of our more vulnerable patients. So when we have received this limited supply, we've been reaching out to those who are eligible based on the Oregon priority criteria. But what's been interesting as we began to reach out to our patients, and these are patients that are either working, so because many of our patients may not be educators, but they might work in janitorial services or food services at school, or they may be caregivers, they do qualify. But what's been really challenging for us as we try to reach out to our patients is that our EHR system does not identify the occupation of our patients. And I think that might be for many of our EHR systems. So we're able to see a person's age and their ethnicity, but we're not able to tell where they work. And so what is happening is that we've actually had to print out list of our patients, and we're just literally going through a list of patients and identifying who we think is eligible just on our own memory. So obviously that's not very efficient, and it also runs the risk of missing many people. So, I just want to, before I kind of move on to talk about the strategies that we've been doing at our clinic, I want to just really emphasize again that there have been major challenges for us. And like I said, it's not only about hesitancy and lack of information, but it's also due to the inability to know when we will be getting a vaccine supply. And so all of that has really been quite challenging for us. So to talk a little bit about what strategies we are using in our clinic. So as we prepare for our vaccine shipment to come in, our clinic has been very active in providing Zoom webinars in Spanish so that our patients can log on and ask questions about the vaccine. We've been partnering with community organizations to bring La Hora Comunitaria, where you have a physician and nurses sitting at a table answering questions from people that are sitting at home using their Facebook Live. We have also been very active in creating PSAs in Spanish. Many of our physicians and our community health workers are making quick radio ads or TV ads that are airing in Spanish and in English, and really just in order to get the word out. But we also are really reaching out to our community partners. You know, with COVID, we really built some really good partnerships with community-based organizations, low-income housing, churches, you know, preschools. And so we've been reaching out to them, and we've been beginning to set up we're starting to set aside some days so that we can do massive vaccination clinics. We also plan to continue to partner with our growers. Virginia Garcia has a long relationship with many growers in our area. And we have been quite pleased that this year they have actually been reaching out to us, asking about vaccinating their workers. So that's been really nice. And we have a mobile van that is able to go out to the labor camps and able to go out to low income housing. And this mobile van has refrigeration so that we can carry the vaccine. Our clinics also, though, have been able to be really nimble, and we have vaccine clinics. We had a vaccine clinic for our staff. We were able to vaccinate 95 people within an hour and a half. And so as we look ahead at getting the vaccine, we are looking also at ways that we can close the clinic down for an hour or two during the day or on a Saturday so that we can bring in the community members to be vaccinated. You know, I think that this strategy of vaccinating our patients at our clinic is essential. It's crucial. What I am hearing on the ground from my patients is that they are hesitant, they are scared, but what they tell me is that if my doctor or my healthcare provider can give me the vaccine and tells me that I should get it, I'm going to get it. And so I think it's really important for us to ensure that the vaccine is being provided in places where people feel that they can trust, where they are familiar with the faces. I think having mass vaccination clinics in some communities works, not with our community, not if they're having to log on into a computer and drive, 20 minutes away, not when they're seeing faces of people that they're not familiar with. So I really think that a strategy is getting the vaccine to FQHCs. It makes sense from an equity standpoint because we are serving the hardest hit populations. So one of the other strategies is we've been really advocating for trying to carve out some vaccine from the federal government directly and bringing those directly to FQHCs. And we just found out earlier this week that Biden's administration will be providing some vaccines directly to FQHCs. So we're really excited and we're looking forward to having those vaccines. In the meantime, what we continue to do as we prepare is that we are looking through our list and identifying our patients that are next in line. We're verifying numbers. We're reaching out to patients. We're asking about where they work. And this is a really nice way to get them ready for the vaccine. So when it's here, they're just ready to come in and give us their arm. Yes.
Do we have some time for a few questions? Thank you so much, but there were a lot of questions coming in. But a couple of things that I think every single panelist has underscored, Lourdes did really well too, is this building. And Lourdes talked about that long, important history of all that work that RCMA has done. And it was all about building trust with the community. Andrea talked about that. Lynn talked about that. And so I think that is a theme that we can walk away with in terms of strategies. Unfortunately, it's not a strategy that you can walk out the door and do tomorrow, but what it does mean is that for those of us who want to reach these hard to reach populations, we need to build on the organizations that do have trust, like your clinic, like Hope, like RCMA, and all those partnerships become so important. In terms of questions, we seem to we've gotten a lot of questions about hesitancy, and what I'm hearing from you and what you just talked about is it's just certainly not one size fits all. But I didn't know if any of you wanted to touch just a little bit more on the hesitancy question, and if you had a few more comments on that.
This is Andrea. Just a couple of things. First, I think that first of all, the vaccine is new. And I think that you have to give people a little bit of benefit of the doubt and lead by example, as we have a little bit of time lead in front of us, given the fact that there are not enough vaccines available. So I think that making a lot of help, making sure that we immunize those community leaders that can talk favorably about the vaccine. I think that we need to immunize strategically. So on the event that we did with the Vietnamese seniors, certainly they fit all the barriers that Eva talked about. They don't have access to the internet, they don't have transportation. I mean, they would never have gotten vaccinated in a mega center in downtown Houston. It was just an impossibility for them. So we worked with people we didn't really know that well. We worked with private doctors that serve these people. So we not just targeted our patients, but we actually worked with our fellow other private providers around our area, because we know we serve them. And if you are in a small area, you share patients with the hospital district, and you share patients with the other providers that people shop around, that they know who charges less and who looks better and where the nurses are better looking, and they will go there. And I think, and so sometimes partnerships are really important, but sometimes you don't need 2 years of knowing each other and be Facebook friends to be able to reach out to them. I think you can do a cold call and say, hey, we have vaccines. We know, how many seniors do you have? And I'll give you 10 slots, 20 slots. Can you fill them in? These are all the forms that you need to fill out. And can you bring them into our event? And I think it buys a lot. It was a big event. Everybody was grateful, but we partnered with people we really didn't know that well. And so I think that maybe that's something you can walk away with.
Thank you so much, Andrea. Martha, I'm wondering, could you turn Lourdes's video back on as well? And then another question that we have is, and I think it's going to be really interesting around COVID testing versus vaccination. So we've got a couple of questions in terms of challenges with accessing workers around testing, but what are your thoughts on being able to work with employers and growers in terms of accessing them for vaccinations?
I know in Minnesota, the employers themselves are looking forward to setting up some employee programs to provide vaccination for their employees. And actually, I'm speaking to a group of grain companies tomorrow to talk a little bit about the vaccine. And they want to know what information would be helpful for their employees. I also think we've got a vaccine that may be coming very soon. That's a 1-dose vaccine. That might be a really good vaccine for our populations that may not, that are highly mobile, and not just our migrant worker. I'm thinking of those who are incarcerated in jails, you know, for a couple of weeks, get a dose, or those who might be housing insecure. So that might be a logistical solution that we may be seeing for this situation. But again, I think as we have thought about and strategized at a state level, we have to be careful that if the employer is trying to build a vaccine campaign, that the employees themselves don't feel coerced, and that maybe neutral parties to provide information might be a better way to get information to the employees, so that it's not the employer that is doing everything.
Great, thank you so much. One of our panelists asked a question early on, but basically said that they learned a lot from some exit interviews, and essentially that they improved their outreach to Latinx community members about getting vaccines when they asked them, why did you choose to get it? And they answered, I did it for my family. So I don't know if you know, any of you have any thoughts in terms of the kinds of questions that you're asking, hearing, and how that's changing your messaging and what you're doing with your patients.
Amy, I'm sorry, was that for?
You can take it, Eva.
Oh, okay. I was looking at the comments here about that. So actually the comment from Lo hice para mi familia was actually a campaign slogan that Oregon used actually. I think so there's a couple things. There's one of the strategies I think, and many people have emphasized this, is I think leaving open-ended questions. I think being curious about why people are hesitant, because it's also easy to make assumptions about why people are hesitant. And sometimes it's something really simple that can be addressed quickly. So many of my patients, I ask them, what questions do you have about the vaccine? Then that's when I begin to hear from them about, you know, what concerns they have. I do think when we work with families and we, especially in Latinos, we tend to be, we are very community oriented, so that if we can do something that is going to help la comadre, el compadre, la abuela, I think that's definitely going to motivate people. So I think that's one. I think the other one is employers who encourage, of course, not force or mandate. I've had many patients tell me that they were hesitant to get the vaccine, and these were care providers, but their employers encouraged it and had it at work, and they decided to get it because they want to keep working. And so I think that one of the ways that we can address is if community health centers could partner with employers. Community health centers are trusted by our patients. Then I think that would ease vaccination at these sites where you don't have, it doesn't seem like it's the employer who's forcing it, but rather the employer working with a trusted community health center. And I think that would also be a very effective strategy.
Great point. I just wanted to share with you, I'm going to share my desktop with you for a moment. I wanted to show you just a couple of people have asked about resources. And I wanted to just share this slide with you that there are a lot of resources out there on the NCN page, at the NRC RIM page, at the CDC. And then in particular, we just put together a checklist of some of the things that you guys all summed up in terms of thinking about the things to, just some of the cultural components about working with this community. They are all available at the NRC RIM, at the Migrant Clinicians website, and we're also going to be sending you a few resources. But that checklist really walks through the underscoring sort of the need for trust, the need for partnerships. If you're an employer, working with groups like RCMA and working with groups like community health centers who have this long history of partnering and reaching and engaging the community. And I think every single one of you have just hit that out of the ballpark in terms of we need to make sure that we have that trusted relationship, and we build on organizations that have that trusted relationship with that. So please take advantage of those websites and looking at them, and know that we're going to be updating. There was a question about like the PSAs and how you got funding for them, Eva, and doing that. And a lot of groups are working, including MCN, to just get those PSAs on our websites so you can use them. And all, I think that from what Lynn and Andrea and Lourdes and Eva, what you have said is all of these resources that are coming out, if you are sharing them, make sure they're from a trusted source that you know is providing evidence-based information. And I think from between all the groups on here today and some of the websites I put up there, that we do offer you that trusted source.
And for us, in terms of supporting whoever we work with, we have submitted list of our locations where we know that we have good parking spaces, because not all of our places are perfect, but we have a lot that do have a lot of parking and space. So we have offered a list of that as well, so that if and when vaccines are available, our places are open for anyone that wants to come. And again, anytime that brings a benefit to our families, we are open and ready to help.
Awesome. Thank you so much, Lourdes. And Eva, I am going to close with, I hope that you all start asking about the work that your people do, and because it's the jobs that they do make such a difference in the kind of care that we're going to be able to provide them. So hopefully your EMRs, your electronic medical records, will now ask if they're farm workers or if they're poultry workers in the future, and know the risks that they face. So with that, I want to just a round of applause, a virtual applause. I can actually do it in person, to all of our amazing panelists. I was so glad to hear from all of you, and you really provided so much insight. And there were some questions that we didn't get to. MCN will try to get you answers to all those questions. At the close of this webinar, an evaluation will pop up. We encourage you all to evaluate and tell us what you think. And also, we encourage you to sign up for our next webinar, which actually is on contact tracing. And yes, it is still relevant as we move forward with this pandemic. So we hope to see you really soon. And I thank you so much. And I'm glad that you all joined us for your afternoon here. Thank you.
Thanks, everybody.